everyone. Welcome back to another STC podcast, Interpreting in Healthcare. We always have really interesting guests from all facets of language access, not just in healthcare, but language access in America. And I am really excited to have the opportunity to introduce to you Lisa Morris from the East Coast. And I want to be able to highlight that if you haven't yet attended a Paving the Way conference, that you should put that into your Google browser, Paving the Way, University of Massachusetts, and find when the calendar is coming up for next spring, because it's really worth going to. And Lisa is really the mastermind behind getting that event together. And it just gets better every year. But before I officially welcome you, Lisa, let folks know a little bit more about you. It's Lisa Medeiros Morris or De Medeiros?
De Medeiros.
Lisa de Medeiros Morris. She serves as the Director of Cross-Cultural Initiatives for Health Consulting at University of Massachusetts Chan Medical School. So that's where the location of this year's Paving the Way was, and it was fabulous. She oversees several projects related to cross-cultural competency with emphasis on language access for all. She has dedicated her career to working in the field of medical interpreting as an interpreter, interpreter manager, educator of interpreters, educator of healthcare staff for the last 3 decades at several healthcare institutions and colleges in New England. She's worked on developing medical interpreter training and conferences, published and presented on the topic of language access nationally. Lisa has served on the board to the National Council on Interpreting in Healthcare in the capacity of secretary and treasurer, and remains an active member. Really, she has helped shepherd our large events in such a fabulous way. She's currently the treasurer and board member of the Portuguese American Leadership Council of the U.S. She has a degree in Romance languages from Boston Colleges and a graduate degree in training and profession and development from Lesley University. And she completed a fellowship in cultural competence leadership in 2007 with the Health Research Educational Trust, HRET, the education affiliate of the American Hospital Association. So fabulous credentials, fabulous background, fabulous work experience, and really somebody that can help answer the 3 questions that we always ask on this podcast with a nice sweeping view. So before we jump into the questions, welcome, seja bem-vinda, Lisa. I'm so happy you're here with us today.
Obrigada, Eliana. É o meu prazer. I'm so pleased to be here and having received the invite to join the podcast today and share a little bit about my history and my goals and what I'd like to see in the future with the audience. Because when I looked back, when I received this invitation, I was like, wow, there's a lot to tell. I've been here, not to date myself, but at least 3 decades. Yeah. So.
And it is true, folks, for all you youngsters out there, that it does compress. Time seems to go faster as the decades roll along. I was like, wait a minute, 2000 was 20 some years ago. So I'm dating myself too. But that doesn't mean we're not staying on top of things and keeping up with the changes. So I'm going to ask 2 questions in one, Lisa, because
Okay.
I'd like you to look back at the crazy lack of anything that there was when we both started working in the field of language access in healthcare, and to where we are now. There's good and bad things about both places, and the National Council didn't exist way back. But looking back, what strikes you as something that either changed your course or brought into focus why language access matters, or the impact that having language access can make? And how does that contrast to how how we do the same thing, but today?
Well, let's get started with where I started. As you said, there was nothing in place. And due to a doctrine of need, which hospitals often are mandated by the state when they want new equipment, at the time, a doctrine of need stated that a hospital in southeastern Massachusetts, in order to get a cardiac catheterization lab, would need to have 24/7 language services provided. And they had nothing prior to that other than calling upon environmental services, which it's called now today, or, a visitor in another room or a staff member, and with obviously with no assessments being done. So you were flying by the seat of your pants basically and hoping that what you were saying to a patient was being transmitted the same way. So based on that doctrine of need and the hospital not really knowing how to fulfill that wish other than a telephonic service, they felt that it was important to have someone manning the ship. I came about, and it was a 180 bed hospital, not a very large hospital at that time, but large enough. And I remember walking in a room and the doctor said, "Why are you here?" And I'm the interpreter for the patient. "Oh, I've worked with this patient before. We're fine. We manage. I really don't think your services are needed." I said, "Well, I'll settle in here in the background. And if I find there may be a need, a perceived need, I'll jump in." And, long behold, every once in a while, of course, there was that perceived need because the sign language or the louder English speaking wasn't really working, or he really didn't understand what the patient was truly trying to say. And so, fast forward many years forward, that same doc remembered that day and said, "How did we do this without you?" And
Oh,
so, to me, it was worth all the effort of going in the rooms and trying to be turned away and saying, "Well, let me just stay." I'm not going to say that every clinician allowed me to stay. They were like, "No, no, no." But I had always kind of linger in the hall just to hear what was going on so that I could glean some nuggets and maybe go back and talk to that clinician about, "Hey, this is what was said. This is what you returned as an answer, but maybe you would consider me in the future." And sure enough, I got my way over time. But, so that's huge to me that we've made so much progress since then. And just because of a document that said they needed to have language services. And the funny part about it is what you and I both know, that the Office of Civil Rights in 1964 had Title VI, which existed well before my starting to be an interpreter. So, I'm like, well, you really had this mandate before, but you just never paid attention to it, or nobody did. And so this is a really big accomplishment, I think, for all interpreters, that institutions and government and insurance are starting to understand that language access is important. It mitigates risks and liabilities, and no hospital wants that liability if they don't need it, especially when it's language and it's not even an issue with surgery going wrong. It's language. We can fix that easily. It's not, surgeries go wrong, unfortunately, for many different reasons, and I'm not going down that path, but language is fixable. It's so easy. So easy, with especially in today's day and age. You have in person, you have video, you have telephonic, and it is a labor of love. To me, it's always been a labor of love. It's a passion. And from there, it was like, we need more interpreters. And so more of my role started to begin to morph into training in-house staff, because that was the best I had at that time. And from the in-house staff, we started to train community folks because in-house wasn't enough, and, release time. And over time, from the hospital, I went into a managed care organization for a while, which was at the time Harvard Pilgrim Healthcare. And that's where I worked along with Julie Burns, who many folks know in the field, and other folks at Harvard Pilgrim to develop the medical interpreter training program they had there. And I helped develop, I helped deliver, and it was a very exciting time. And Harvard Pilgrim basically not only trained their staff, but they also trained community, and it became quite a large program until Harvard Pilgrim got sold and became another company. However, the training unit still continued under their diversity, equity, and inclusion.
Good. And I have to explain for anyone listening, when you first started and you said back when you began your career and you would walk into the exam room and the physician would say, "Who are you? What are you? Why are you here?" I burst out laughing because, yes, so many times I was in that situation as well. And you would just try to get them to agree to let you be a fly on the wall and wait until something went off kilter. And then the ease with which that could be corrected was the experience that sold people every time, unless, of course, it was a family practice. They really appreciated the interpreter from the get-go, but all of the other disciplines, that suspicion of, who are you here? Isn't this violating the patient's privacy? Why? We don't need you. We get along fine. And then the discovery of like, wow, I've just been skimming on the surface, and with the assistance of a trained interpreter, I suddenly got to all these deeper, more rooted things that are affecting whatever it is, medication compliance or the ability to not be late or show for appointments. You know, the backstory is usually not obtainable when you're using your weekend Spanish or your sign language that you made up yourself to try and communicate with somebody that actually has a very strong language of their own, but it isn't English.
It's as simple as I remember one story where they called me for discharge instructions with a patient, and I had never seen the patient throughout their stay. And now I'm here at discharge, and I'm like, oh, wow, I didn't know. Oh, well, his daughter was his interpreter, and they're doing discharge, and he was in the cardiac unit. And they're like, oh, now they're reviewing meds, and they say, oh, this medication is Colace. It's to help you move your bowels. And he goes, oh, thank God. And the nurse said, what are you? And so I said, oh, thank God. She's like, what does he mean by that? And I said, what do you mean by that? He goes, I haven't gone for days. But when they researched, they found out that the daughter never asked that question because it was too uncomfortable to ask her father had he moved his bowels. So now he ended up not being discharged and had to stay in until they were certain that he was regular again. Yeah, because that could cause another problem to his heart for the stress. So.
Oh my goodness. Yes. So it's layers of the onion, isn't it?
Oh, yeah.
Once you begin to peel and you realize, oh, there's another one. Oh, there's another one. Oh, there's another one. It's that light bulb moment, I think, that sells people on qualified, certified language access as opposed to Google Translate or, oh, I've been using my phone, or the weird stuff that you hear. What do you see currently as the biggest challenge then? Because things have improved in some ways in terms of awareness, and laws or legislation is finally starting to tighten up a little bit in a way where people have to pay attention because it's specific. But it's been a long time coming, and it's still no big financial penalty for not paying attention to Title VI. So
correct.
what do you
Yeah.
think is the big one that we need to deal with right now?
I think right now is the concern with the ease of accessing AI or even Google Translate, which is better but not perfect. A lot of technology is great, but until the human factor puts in the information, what you get out is limited to what's properly put in. And that concern,
garbage out, right?
right. that concerns me because we all carry a cell phone and it's very accessible. And we know that docs and nurses, anybody in the clinical arena, don't like to wait more than 2 minutes or 30 seconds
30
even.
seconds.
30 seconds. So can you imagine if they can just take their phone out of their pocket or their laptop or their computer and get done what they need to do?
And the challenge is that it could be so good someday, but we aren't quite there yet.
No, we're in infancy
So we don't
stages.
want human guinea pigs in healthcare situations, but we do want to partner with the people that develop this. So developers out there, stop bringing us language access people to the table after you've completed your design. Please bring us to the discussion sooner. We want to help make these things work the best way possible, not the halfway possible. And that's only possible if we have discussions, if we aren't siloed away from each other. So yes, see
I
the
completely agree
potential,
with
but
that.
we're not there yet. I mean, yes, for repeatable things that have no nuance, like do not park here. Yes, please translate that into all the languages. But anything with nuance, anything with affecting your liberty, like in court, or your health or your life expectancy, like in the hospital, we're not there yet. Let's use it in the other places first. I don't know. Maybe I'm too cautious, but
Well, I believe there is a place for AI right now, most definitely. I mean, it's okay, and Chat GPT and whatnot. But I think that we have to proceed, as you say, with caution. And the human factor goes a long way, especially in healthcare, where there could be a lot of emotions running high and people trying to communicate something that has more spirit and tone than what the AI is coming across with, for the clinician to really understand, whether it be the excitement, the fears, the woes and the aches that people may have.
And in addition to all of that nuanced component that comes from being a live human being as opposed to a dictionary entry, the challenges with AI have a lot to do with the fact that remember the garbage in, garbage out thing I said? All of the inputs in English. It's like overrepresented by 10 times the next most common language. So all of those language nuances, right? It's not emotions, but they're colloquial expressions, they're slang, they're acronyms, there are all sorts of things that there may not be an equivalent in another language. It's all being fed in English. So it's going to think in English. Does that sound too xenophobic of me? But it needs to think globally in order to embrace all the languages. And right now it's thinking in English, if that makes sense. So those are the worries. That's why we need to have some oversight, someone that vets the output, and then that puts the kibosh on the instant gratification of sticking my hand in my pocket, getting my phone, and saying blah 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 to my patient at 3 o'clock in the morning when no one's scheduled an interpreter or access to a video remote interpreter in another time zone where they could be bright-eyed and bushy-tailed.
Exactly. Yep.
So looking forward, normally I just say looking forward, what do you see as the big challenge? But I'm going to try to tighten that a little bit and say, how can we have more dialogue with the people that are building these large language models and working on AI? Because if that happens, it'll be better, inevitably. How can we make that happen? I don't know.
That's an interesting way to put it. And a light bulb just went off in my head, as you mentioned in the beginning. Paving the Way has been around for 19 years now, and we're going into 20. Maybe it's inviting a panel of those developers to the table just for a focus group Q&A to hear us out as well as hear their story and how they program. Something like that, a webinar of that fashion.
Something where we could somehow communicate. It's like we really need to partner. We don't want either side to minimize the potential contributions of the other, but I think you would have a much better product if language access people were involved sooner rather than being presented with the finished product. Okay, now make it work in other languages.
Yeah, it would be a very interesting conversation. I mean, because right now, as you said, it's very linear in the way I see it, all in English. And, I think that if you have a round table with the proper people at the table, the developers, maybe OCR, maybe Office of Minority and Immigrant, Office of Refugees and Immigrants, the maybe
Migration Policy Institute.
Right. And interpreters at the table, or NCIHC and the CCHI and NBCMI, have these folks all at that table and have a very deep conversation about how can you partner with us? How can we help you? Like, we need to extend our hand and shake in the middle and know that we're going to move in the right
Like
direction.
A summit.
Yeah. Exactly. And there will be a summit in 2025 with the NCIHC called the Congress, actually 2025. And I'm actually chairing that with Enrica Artemagné. And maybe that's the place where we can have it happen.
Yeah, I think the more the merrier. So maybe it could be a two-pronged thing. It doesn't have to be the entirety, but it could be like a plenary session where you actually have the players at the table, and it's not meant to be divisive and to take sides. It's meant to look at ways that we can be stronger by coming together.
And then develop a white paper from it.
Woohoo. Well, look what just happened, folks. We were just going to have a nice conversation and ping, 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 brainstorming. But, the wave comes when the wave comes, and you either ride over that swell or you start paddling to try to catch it. Very Brazilian metaphor there. It's always about the beach. But right, what they say about good luck is really when opportunity comes across preparedness. I'm ready, and now I'm looking for an opportunity. And when it comes around, you snag it. And we've got to snag it in order for this AI technology to roll out in the way that causes the least harm and the most benefit. I mean, we all want increased accuracy, accessibility, 24 hours, but without sacrificing quality.
Yeah, at the end of the day, it's about the end user, the patient who needs services, the clinician who needs someone to communicate for them, the attorney, the witness, the defense, and anyone who needs language access, and we can't sacrifice the quality to sacrifice what the end result might become without that language access.
We have to remind folks, it's patient-centered care, it's client-centered care, and yes, the bottom line matters, but it's not the center.
Right.
It's the end
and
user.
It's safety.
Yep.
Mm-hmm.
Well, thank you so much for joining us today, Lisa. And
thank
everyone
you.
out there, go research Paving the Way and keep your eyes on the listserv or our NCIHC website for more information about the summit next year. But yes, when folks who have some passion come together, sparks fly. So thanks for helping make them fly today, Lisa.
Absolutely. And folks, you can always visit www.massmedicalinterpreting.org to keep on top of the Paving the Way conference. And you can also see the archives of past conferences and speakers and our Tony Windsor awardees and the current and past. So I highly recommend it.
All right.
Thank you, Eliana.
Being with us today.
Ciao.
Ciao, ciao.